All right, let's come to another small ruptured aneurysm. I mean, we want to discuss them because these are all of us see them a lot. These are major practice. So something like this, how would you treat? You can again go back. Small ACOM.
Intrasaccular.
Ah, yes, you are absolutely right. Intrasaccular will be wonderful here. And so, which one would you use, web or contour?
Web here, because it is O17, so you can go very distal, easy, and it has the shape, so.
Perfect, perfect. Yeah, I mean, yes, it does look like a great case for web. I mean, the problem in India is, I think the problem with us, because it's more costly than coiling, and because we end up doing coiling, none of us have done that many webs. None of the, I think, 100 webs in this country, so, and that becomes a challenge. So, and Ajay, coiling.
Balloon assisted.
Yeah. In fact, as soon as this picture came in, Ajay was like, okay, simple. Done. Yeah. So, nothing complex about this case, just maybe we want to show some simple things. Balloon placement. You'll use a balloon or not?
For these narrow neck and when the aspect ratio of aneurysm is good, so we do simple coiling just to save on the money. The balloon is there on shelf, so if I need it, that is by secondary intention. But in such aneurysms, just a simple coiling, microcatheter and coils. That's it.
Great. I mean, you are right. I mean, we use balloon because I feel the challenge is not coiling. Challenge is to pack it in a way at the neck that don't come back. Again, as I said, number one, indentation may not follow up, or in follow-up, you have to do a stent and coil. The cost issues are there. So, to me, the problem of balloon-assisted coiling is not the coiling part, it's trying to reconstruct, so the chances of recurrences are as low as possible. And
especially
with time,
this tubular, especially tubular aneurysms, the coiling packing density may not be optimum if the balloons are not used.
Yeah, and another thing is, if you go back, if you see in this plane, I'm sorry, we are going ahead. Let me see. Yeah, when they are superiorly pointing, you know, when the inferior pointing, microcatheter points very well, and you can pack them hard. When they're superiorly pointing, microcatheter tends to back out at times, and then you're stuck with it, right? So I really wanted to pack it at the neck pretty hard, and as I said, most of these cases nowadays we just use balloon because it is so convenient, and very few cases there is severe spasm or something like that that we'll do without a balloon. All right. Another thing which I would like to show. Okay, so the challenge here is to take the balloon safely in an angulated artery. As I showed, we're just trying to show. I always use the needle to shape the synchro. We form that pigtail shape, which we are very fond of, and we sort of rotate my finger around it to give it a very, very tight pigtail-like shape, which I find very useful to catheterize. Then after that, it's not a problem. And in these cases, we like to use, when there's a sharp angle, we like to use double lumen balloons. And as you see, with that shape, it's not so easy, and we send the wire very distally so that balloon goes in without much trouble. So we tend to take a wire very distally, and then you just withdraw the wire, and the balloon is in place. After that, at times we take a repeat roadmap, as I mentioned, because, and in this case, again, it was superiorly pointing, so we'll give a reverse shape, because routine inferiorly pointing aneurysm you can do with a J. Here we'll give a reverse shape. Just to show you here, 1 second, see, okay, what happened here? Can somebody, something, 1 second. Guys, can you help? Okay. You see, whenever I'm touching, let us go back. Somebody has asked about the shape, so let me go here. If you see here now, how the microcatheter is pointing superiorly in this angle, and the wire shows the shape of the microcatheter. In this plane also, you can see it's pointing towards the neck, so we don't really enter the aneurysm. When it's pointing like this from the neck, we know we can peacefully coil it from there. Sizing of the coil is very important. The first coil you want to come up to the neck, And in this case, we use a long coil. In spite of that, it kept going in. As you mentioned, tubular aneurysms, this can be a problem at times. So I'm coiling practically from the neck, and we haven't inflated the balloon at this point of time. Okay, anyway, once balloon is there, so when the catheter is trying to back out, then we inflate the balloon a bit to put in the last part of the coil there. And more coils at the neck. We know with balloon in place, we wanted to pack the neck very, very well. Problem in India, repeat treatment is the cost. Small neck is left. And then we decided to place more coil at the neck. But the coil should sort of integrated with the previous coil. You can't have loose coils loops there, okay? And what we are doing here, there was a small projection near the neck here, and I really wanted to get it. So I was okay with, again, some small tip remaining outside, but I wanted to get that part of the neck around here. You can see it was shaped like this. So we managed to place one more coil, little bit tip hanging out. I thought I can live with it because now we can safely give her aspirin or anything and get this shape in the end. So give us the best chance that there is no recurrence. Small tip remained out. I was okay, I detached it. But rather than taking out that coil, because to me, that shape was very, very important in trying to prevent a recurrence. Only follow-up will tell us how well the patient does. So I don't think there is anything further. So when a tip like this is out, we watch it for a while. But small coil tips usually don't cause any thromboembolism. We just gave more heparin and aspirin, and the patient remained fine. So just to say, we love balloons for this reason, because it's not the coiling part. You have to get a dense packing in. Number two, in Indian patients, we have to coil the neck as well as possible. We can't have this, will bring back the patient. Most patients will not come back. And we have to try to have a dense packing, not just some coil loops in. Balloons, they're very useful. The shape of the microcatheter is very useful. Most of these cases, we just coil them from the neck, small ones. And whenever catheter starts to back out, you can inflate the balloon, make it stable. And small tips hanging out, will live with that rather than underpacking. And we know patient down the line will need a repeat treatment, which gets complicated mainly because of financial issues. Yeah.
Actually, that small tip that was there in the end of the procedure, I think we need not bother too much about that. We have to put on the antiplatelets,
Yeah.
which I usually follow in almost every case in the ACOMs. We put the aspirin, one to prevent the thromboembolism, and I have a feeling that when you put the patient on aspirin, there is a hypothesis that delayed cerebral ischemia happens due to the microthrombi. Aspirin prevents that. So I have seen that after putting the patients on this, the incidence of the delayed cerebral ischemia is less. I am not telling it is completely ruled out, but it is less.
Raj Nivas, where is Raj?
So it's my practice, almost every case I put the patient on aspirin.
Yeah, that is useful when you are doing such kind of packing near the neck. Even if coil tip is not hanging out, clotting can happen. So number one, same thing. We increase the heparin, we watch for any clotting, and after extubation, even if you don't have a right to give them aspirin and give it for a few weeks, and that usually suffices.